Afternoon to everybody. I'm really sorry I was not able to come in this great congress. Ciao Lorenzo. This is my disclosure. Now, the first topic I want to share with you is SAD and MAC that are two faces of the same coin. We published some years ago this paper, and we have demonstrated that small artery disease is strongly and independently associated with the CLTI. It must be considered the main actor in CLTI. The power of the obstructive disease in leading to CLTI is stronger in the distality, the below the ankle vessels. I tried to summarize this concept in this way. These are the odds ratio for CLTI of every localization of the disease. As you can see, to get CLTI, we need many obstruction in above the ankle arteries. However, in below the ankle arteries, we have a odds ratio which is so important, so huge for CLTI, that this distribution failure is able by itself, without any other type of obstruction above, to lead to CLTI. We have also demonstrated that the sensibility of the MAC score and the specificity in detecting the SAD score is so high that we can conclude that MAC and SAD are two faces of the same coin, are two faces of the same type of disease. So the overlap between SAD and MAC is so complete that they must be considered the manifestations of a single disease. Second topic, why MAC and SAD are associated. There is an open question, because MAC, medial artery calcification, is outside the lumen in the vessel wall and in itself is not obstructing the lumen. How can be MAC responsible of SAD? What is the material obstructing the lumen? I think that intimal thickening could be the answer. Monkeberg wrote in 1903, in the highest degrees of MAC, the artery is transformed into a rigid tube. On such vessels, there is usually a diffuse intimal overgrowth. And in this paper, in 176 upper and lower leg arteries studied after amputation due to critical limb ischemia, the most common findings were calcification of the media in 72% of the arteries and intimal thickening without lipid, 68% of the artery. With the presence of atheromas, only 23% of arteries. Non-atheromatous intimal thickening was frequently severe, resulting in complete occlusion in some vessels. For this reason, we decided to do a study, an anatomopathological study on amputated limbs. We collected 26 amputated limbs in the University of Parma due to CLTI, and these are the preliminary results. We get samples of superficial artery, popliteal artery, of proximal tibial arteries, tibioperoneal trunk, distal tibial arteries, and of dorsalis pedis, lateral plantar arteries, first metatarsal artery, and digital arteries. And what we observed is this intimal thickening, very strong, very intense, associated with the medial artery calcification. These are the results, but we can we must understand deeply these results. Okay, this is atheromatous lesion. As you can see, 90% of the samples in SFA presented atheromatous lesions, and half of these were obstructive atheromatous lesion, obstructing more than 50% of the diameter of the lumen. So atherosclerosis represents most of the lesion in fempops, then disappears in BTK and foot arteries. Disappears in BTK, only 15% of the lesion were atheromatous. Second, medial artery calcification, and you can see it is this medial artery calcification is present everywhere, and intimal thickening, the same, is present everywhere, and they are significantly associated. Intimal thickening is non-obstructive in SFA and POP, and highly obstructive in BTK and foot arteries. So what are the obstructive lesions leading to CLTI? We observe in SFA and POP a high percentage of obstructive atheromatous lesions. And in POP starts the intimal thickening that is the highest in BTK and foot arteries. So we have about 50% here decreasing, and then the rising of intimal thickening obstructive. So this is the first anatomical study. But why does medial artery calcification lead to intimal thickening and small artery disease? Why there is this association? I think that we have two answers. The first is arterial wall stiffness. We made a computational model-based analysis of endothelial shear stress of the lower limb artery. We divided in hundreds of small pieces of 2 or 3 centimeters elements, or this model of the inferior limb arterial tree with this equations that represent the resistance, the elasticity of the wall, etc. And we measure the shear stress. We know that the normal range of shear stress in arteries is between 10 and 79 per square centimeters. Below and above these limits starts endothelial sufferance, atherosclerosis-prone arterial regions, and high shear stress thrombosis due to complex plaques, etc. So generally, the endothelium tries to maintain this set point of quiescence. If we go up, we start a northward remodeling of the vessel, like in the arteriovenous fistula of the upper limb in patients on hemodialysis. If we go down below this level, we have an inward remodeling. And this is these are the results of this attempt to understand in this computational model what happens with increasing stiffness. We start with the baseline elastic Young module, and then we increased the stiffness, reducing the elasticity of the vessel wall of these segments 4 times. These are these different levels of gray bars, and you can see that in SFA, in POP, and BTK, and in foot, we have a different behavior, because the normal shear stress is maintaining the big vessels, but in the small foot arteries, the higher the stiffness, the higher the shear stress change in small vessels. So a high shear stress acting on endothelium gives signal to vascular cells to proliferate, to increase vessel diameter, outward remodeling. Vascular cell proliferation is prevented by the MAC shell, so they are choked inside the vessels, and vascular cell proliferation results in intimal thickening and lumen reduction. There is also the flexibility failure. We have this paper by Oscar Cloth, published in 1916, when an artery suffers advanced calcification, acute flexion may fracture some of the calcareous rings, particularly when the tortuous course of the vessel does not permit it to move readily, nor to adapt a more easy curve in the surrounding tissues. Fracture of arteries. And now observe, this is an artery, typical artery with medial artery calcification, diffuse medial artery calcification. I'm trying to do a retrograde puncture. You can see that we have some bone-like small segments and some fracture points. This is an artery that has lost completely any flexibility, and in this fracture point we have the concentration of all the forces that act on the arteries during flexion, during changing our movement. And if we look at the distribution of the stenosis, I think that only one patient, this patient, can clearly let you understand that the stenosis and occlusion are concentrated on these fracture points. So in conclusion, arterial stiffness could be associated with arterial fractures leading to intimal thickening, stenosis, turbulence, and thrombosis. Is the prognostic value of the MAC score. We have demonstrated in our paper that we have this never healing wound, the salami effect, the DRG factory, and the never ending story in the patient that present a very high MAC score. And these data were confirmed using the same MAC score by the group of Michael Conti in San Francisco, the group of Di Bartolomeo, these Korean guys, and they have also demonstrated, these Japanese people, that no outflow of the target vessel, the MAC grade and occluded pedal arch were independent predictor of the technical failure, inframalleolar angioplasty, and severe PMAC is associated with amputation and should be considered as a variable in the shared decision making of the diabetic patient with CLTI. So, in conclusion, CLTI patient with a high SAD-MAC score presented 2 year only 30% healing, high risk of major amputation, revascularization, failure, foot and vascular intervention. This no option CLTI patients should be considered for alternative therapy, such as primary major amputation, palliative care, or foot vein arterialization. Thank you very much for your attention. I am sorry not to be there with you. Ciao Lorenzo, ciao a tutti.